Hello, everyone. This is Robert Shaw, and I'm here to present some training about writing items for the new Respiratory Therapy Secure Self-Assessment Examination. The audience here are individuals who have volunteered to help us with this new examination. And so we have some particular things to discuss because this is a unique examination, being sort of the product of merging the therapist multiple choice examination and the clinical simulation examination. So we'll get into some of the details about what makes this examination, its content, its items unique. We have on this next slide the objectives for training. I intend to illustrate the characteristics that we're going to ask you to integrate into these items. Understanding that the examination contains two distinct portions, a breadth portion and a depth portion. And in greater detail, talk about when your job is to write a handful of items, managing content domains, tasks, cog levels, patient types, clinical judgment type, which I'll ask you to think about the sim exam and the fact that some of the times you're asked about what information you want to gather as opposed to the decision you want to make, to help describe what that means, and then setting, which would be, is it happening, is this scene, this interaction between a therapist and a patient, or the medical team and the therapist, is it happening in a hospital or out of a hospital? And then lastly, we do have a small number of items, or expect to have a small number of items, that ask folks to think about medical ethics principles as they're considering which of the options in a multiple choice item to select. And so those first two bullet points cover things specific to this examination. The remaining bullet points are broader item writing kinds of topics. If you've participated in item writing training before with the MBRC, likely at a summer forum in the past, then we've hit these points before, but it's useful with this new writing task to refresh some memories in case you've been exposed to these ideas before. And for folks who've not been through that training, this will be new. And likewise, critical to your having success in producing the kinds of items that we need for this new examination. So moving forward, we're going to get to some specific points about this new exam. And first describe in greater detail where the items are going to go. The examination is going to contain 160 multiple choice items. 100 of those will be designated as intending to assess the breadth of knowledge. This is what the current therapist multiple choice examination does. And then 60 of those items will be intended to assess the depth of clinical judgment, which is what the simulation examination does at present. And so that's where we came up with these two portions. Each of you are going to be asked to write 4 items. And each of you are going to get a mix, some from the breadth portion, some from the depth portion. I can't promise that it's going to be an equal distribution. I mean, looking at the sort of the number of items in the examination should tell you that we're going to need a few more breadth items than we will depth items. And so, those will likely dominate across the assignments that we give. One other thing to think about is the results that come from the secure self-assessment examination, the reports that are generated, how programs use those reports is another consideration. And if you've experienced that before, then likely you recognize that you might look at a group of your graduates or recent graduates and look at the reports generated in regard to, say, content domain, and ask yourself whether there are adjustments you should make in your program based on what you see about strengths and weaknesses regarding content domains. Likewise, you may look at reports in regard to the complexity or the cognitive levels of the items, and perhaps observe that while your folks do well with recall items, it's a greater struggle with maybe higher level cognition. And therefore, again, the question is, how can we or should we adjust our program in order to help folks do better in that regard? Patient type is another one of the categories in which some information can be summarized about groups of test takers. These come from the current simulation examination that will be transported over into the new examination. But there will be a subset of items that involve patients who've experienced some sort of trauma with some respiratory consequence that requires that they need that kind of support, or they may have a neurologic condition or neuromuscular condition. Likewise, they could have directly have some sort of lung disease that may be chronic or acute in nature that needs to be addressed. Or we could have a premature neonate who is being supported through respiratory distress syndrome, just as some examples. There's a longer list of patient types. It's in the content outline. That content outline has been published to the document library at mbrc.org since June. And so any program can take a look at what's in the content outline and see the full scope of the different patient types that could be expected. But boiling this back down to our task, we will have distributed those different patient types across the writers as the examination needs. And so that's, we'll be asking you to produce some somewhat specific content in that regard, especially when it comes to the depth items. Lastly, there could be reports about groups of graduates and how they do when it comes to information gathering kinds of activities as opposed to decision making. And then again, the same question comes up, which is does this indicate to us that there ought to be some sort of a change in our program so that our groups folks in the future can do better with that sort of content? So again, we're going to have both breadth items and depth items within each set of assignments, and a little more detail about what to expect within those assignments is described here. So for the breadth items, you're going to find that each assignment is going to contain a content domain, a task designation that's subordinated under the domain, also a cognitive level. And then it's possible that a small group of the items from the breadth section will ask you to incorporate some content that stimulates some thinking about medical ethics. Within this set of items, it will be designated in the assignment that the writer has the option to choose to add information about patient type, clinical judgment type, or setting. Now, on the front end, when you first see the assignment, all it'll say is you have the option. And so my advice is focus your attention on the content domain, task, cog level, and write your item to fit that content. After it's written, you should look back at the item and say, okay, did I talk about a patient of a particular type? Did I set the scene in a hospital or out of a hospital? Did I ask a question about information gathering or decision making? And if the answer to any of those questions is yes, then you should change the nomenclature description for the item just before you submit it so that we're alerted to the fact that you've added in this optional content. When it comes to the depth items, the focus should be in a different place. You should focus first on the patient type. That'll be primary for that set of items. Also, we'll designate whether we need this item to be about information gathering or decision making. And also, should it be set in a hospital or out of a hospital? And so you need to help us by following through and satisfying each of those criteria for these depth items, because they're supposed to exist in certain proportions. In other words, there's supposed to be a certain proportion that are set in a hospital as opposed to out. There's a certain proportion that's supposed to be about information gathering and a different proportion about decision making. And so we're asking, please don't freelance in this regard. If the assignment says do X, then please do X. Now, secondarily, you'll see this last bullet point on this slide talks about the writer choosing the content domain and tasks that fit the additional content that's added in the item. Again, this is something that won't be known to you really until after it's written, potentially. And so there's sort of this second phase of looking back at the item that you've written and say, okay, where does this fit in terms of the content that's described in the breadth portion of the detailed content outline? Another key point is that it must fit somewhere in that breadth portion. You can't write an item about a patient type that gets into an activity that's not described in the breadth portion. Otherwise, it's not usable to us. So that's another key element for me to emphasize, and it's sort of part of the special character of this examination. So that's something to keep in mind as you begin to tackle your item writing assignment. Moving ahead, let's again drill in a little bit more about managing your item assignments for the breadth portion. So again, when you get the option to integrate patient type, clinical judgment type, meaning IG or DM, and then the setting, meaning in a hospital or out of hospital, once again, it's best to start by writing your item to those issues, that meaning the task and the cog, and then after it's written, again, look back and see how that's going and where do the other elements fit. Another point that occurs to me is that if your assignment is to write a recall item, then it's a lot less likely that you're going to need to bring in information about patient type, clinical judgment type, or setting, because these recall items are more often generalized in their truth in applying sort of across the board. And so it's, again, less likely that you'll need to bring in those other content features, namely patient type, clinical judgment type, and setting, when your assignment is for a recall item. The converse of that is when you are asked to write one of the higher level of higher cognitive level items, that's when you're more likely to need to pull in the other content. And that's kind of illustrated here with 3 potential assignments from the breadth portion, where you can see over on the right-hand side, content domain, task, and cog, as well as ethics, are predefined by us. And so it's your job then to pull out scenes from your background and experience, something that fits that content description, as you'll find it in the content outline. And the points about patient type, clinical judgment type, and setting are literally optional at the point that you start writing. But then again, after you've finished, we're asking, look back and see whether you've incorporated any of those other elements, and then adjust the classification of your item accordingly just before you submit it. So now let's talk about managing an assignment from the depth portion of the examination. And I think a key point for me to bring forward is a handy tool for you will be to assume you need to include a table of vital signs with your item. And what you see over to the right-hand side of the slide is a kind of a quick visual template for the way I expect your items will look when they're intended for the depth portion. So we have text above the vital sign table. This is going to introduce the patient, set the scene, give whatever details are necessary about the patient to get the candidate to start to understand what the situation is. And then we get to a table of vital signs, which should continue the story. And so you, the writer, have control over the values that get inserted into the vital sign table. And so if your intent is to tell the story of an unstable patient, that needs to be reflected in the vital signs. You also need to think about in what ways is this particular patient unstable? Are they hemodynamically unstable? Is their oxygenation low? Do they have an infection? And depending on your internalized response to each of those questions, that should tell you the sorts of values that you should insert into your table so you can continue to tell the story. Now, below the table is more text. And this is especially going to tell us and tell you whether your question is focused or directing the test taker to gather more information or make a decision. And so that's where you're going to embed that sort of information. Then we flow on into the options. Another key characteristic of items in the depth portion is that there's no recall allowed, no recall items allowed. So everything is either an application level or analysis level. I guess the good news is you get to choose which of those two you're going to use for a particular item. So we're not going to predefine that in the depth portion. And so that's another contrast between the two portions of the examination, because cognitive level is very precisely defined for the breadth portion of the examination, while it is not for the depth. And so again, you're going to bring forward the other information, like where is this scene set? Where am I going in terms of prompting someone either to gather the next bit of information that'll be useful for this patient or make a decision about the patient's clinical course. And then lastly, you got to find a task back up in the breadth portion where the content of the item best fits, and tell us what that is so we can accurately capture that in the item bank. Real quick about ethics items. The first is that we will predefine this. And so please don't freelance and add ethics where we've not asked for it. And if we have asked for it, then we need to see it. You need to fulfill that aspect of the item content in addition to all the other things that we've asked for. And I recognize that that's asking for a lot, but again, this is part of the unique nature of this examination. So specifically when we're talking about ethics, we're talking about the 4 principles of medical ethics that you see here in the middle bullet point: autonomy, beneficence, justice, non-maleficence, also known as the first do no harm principle. And so a typical ethics item is going to include an incorrect answer, also known as a distractor. That's going to describe doing something that is less than fully ethical. A couple of examples are here. So you could have a distractor that offers intubation after the STEM has already told us that the patient doesn't want it. Either there's an order in the medical record, perhaps, or they brought outside documentation in, an advance directive perhaps, that tells us that they likely don't want this, and yet we have a wrong answer that says, let's do it anyway. Or in real time, you could have a competent patient simply refuse to consent to the treatment. So any of those sorts of things can work when it comes to coming up with an ethics type of an item. And that's probably the more common one, the one that jumps first to mind, but it's not the only one. There's also the time when you let non-maleficence or do no harm override the potential benefits of getting new diagnostic information about somebody, which would perhaps require that we physically move them through the hospital to some other area. But at the moment, it looks like they're too unstable to tolerate or survive the transport. And then one other area where ethics can play out is in the area of justice, where all of a sudden, perhaps because of some sort of mass event, we now have more limited resources than we have patients, and therefore now some decisions, some triage needs to occur. Another scenario is you have some highly technical kind of treatment that you're going to offer, or even surgery. Can't necessarily start up a surgery at any point during the day, especially at night. And so, making decisions about allocating, say, ECMO systems to you may only have 2 or 3 in a hospital, but you got maybe 4 or 5 patients that could use ECMO at a particular time. So there again is another way to create a scene in which somebody will need to think about the medical ethics principles. Now, when it comes to satisfying the assignment and looking first at the breadth section, which is illustrated over on the left-hand side of this slide, you'll find those descriptors within sort of the body of the content outline. And you need to pay attention to the content domain headings as well as the task statements in order to fully understand what it is that we're asking for within the item. One other little tip is that we intentionally designated the outline structure using Roman numerals for the major domains, because we then, when we got to describing the depth and labeling the depth areas, which are primarily organized around patient type, we chose to use Arabic numbers instead. And so that alone, once you're more deeply immersed in the content outline, should be hopefully apparent to you what this assignment is referring to, just paying attention to whether it's a Roman numeral or Arabic. But if you look then on the right-hand side, you get greater detail about the content that can be brought to bear for the different sorts of patient types, whether it's a 1A3, which is supposed to be about outpatient management, as an example, as compared to a 1A1, which is supposed to involve intubation and invasive mechanical ventilation for somebody who has chronic lung disease. Those descriptors are there in the document. So it's going to be worthwhile for you to go find the content outline and study it and pay attention to it and link what you find there back to your assignments. We're going to transition now away from things specific to this respiratory therapy secure self-assessment examination into a broader topic of how to succeed when writing items. And we'll start with the guessing strategies that individuals will use when they encounter multiple choice items. And the other key characteristic to keep in mind is there's no penalty for making a guess at a multiple choice item when you have not fully mastered the content that's being presented to you. And so you should anticipate, as a writer, the different kinds of guessing strategies that people are going to deploy, and take steps within the construction of the items to mitigate against them being able to succeed with an item for the wrong reason. So that's why we're covering this ground. So we have a set of options here that are fractions. And we have the tendency, I would say, of candidates who guess will start their approach at guessing by counting the frequency of occurrence when there are multiple parts or multiple pieces presented in a set of options. And so we have the number 3, the number 8, the number 4, 1, 5, and 9 kind of distributed among these options. So someone who's going to guess will start their approach, again, just by counting the number of times that the different elements are offered. And they'll begin to see something emerge, a pattern, which is that the number 3 gets used a couple times, the number 8 gets used a couple times, the other numbers are only used once. And so from the point of view of somebody who's making a pure guess, they are going to be attracted to any option that makes more use of the more frequently used parts. And so that occurs here with option A. We call this convergence, where the more frequently used elements converge in a given option. And this also illustrates a tendency for folks who are relatively new to this kind of writing, and that is they'll tend to overuse the correct bits of information while underusing the incorrect bits. And they have a logic behind that, which is, well, the candidate just needs to know that this is wrong, and then they'll have a better idea what the right answer is. But what we need to do is sort of camouflage the wrong answers by using them just as often. And so a solution, as you'll see over to the right-hand side, is stop this business of repeating parts and only use each number one time. Therefore, when a candidate guesses and see those, they're not guided or pushed in one direction or another. So that's one potential solution when you see parts or elements get repeated within or among the options. So here's a similar problem, but as you'll see, a different solution. So here we're using words instead of numbers, but the same principle applies. A guessing candidate is going to start counting how often the different elements are presented, and they'll see that option B has a convergence problem, again, just like we saw before. But the solution this time is different, because this time we're going to live with the fact that we're going to repeat some elements. We're intentionally going to repeat some elements. In fact, we're going to repeat the wrong elements just as often as the correct elements, and this is our camouflage strategy. And by so doing, then there's no real tip-off, or there's no encouragement to go toward an option or away from an option for the subgroup of candidates who are making a pure guess. One other detail about this solution on the right is, in case somebody might think that sequence matters, we've intentionally mixed that up, offering each element in the first position in one option, and then in the second position in the other, or the second option. And it's that kind of extra layer of care that we are encouraging you to bring to the items that wind up being submitted for this examination, and that will help encourage success. And by success, I mean that we wind up accepting the item and agree to present it to the committee of your peers, your educator peers, who wind up being selected for the committee, who will approve each of the 160 items for this examination. So here's a different kind of a problem where we have values, numbers in the options, one of which is an order of magnitude separated from the others. And so it stands out. Visually, it stands out. And so the question is, what do we do with that? Well, here's two possible solutions. One is we could come up with a second value that is in the range of the lower value. And so a guessing candidate will take a look at the top set and conclude, oh, here's two pairs of things. So where is the correct answer within these two sets of pairs? The alternative solution is to just give up on the idea that we're going to offer a low number and instead replace that low number with one that's up in the range where the other numbers fall, so that they all appear sort of in the same zone to the candidates who will guess. Here's another problem that we see frequently, which is that a writer will draw a distractor from a different family of ideas than the other options that are offered. And again, this is a typical sort of a mistake that we see writers make. The way to avoid that is write your key first and then pay attention to the family sort of in which that key belongs, and only draw or limit yourself to drawing wrong answers from that more limited family of ideas. That's more challenging, but it is a key component to, again, succeeding when it comes to writing these kinds of items. And so that's an illustration of what we oftentimes see. This is indicating to us that there's three possible solutions to this problem. On the left-hand side, we just continue the idea that we're going to stay inside this family of ideas, and then we're going to mix that with the words increase and decrease and have two of each, again, to create the idea that there are two pairs. And so that makes it a lot less likely that somebody can game the item through guessing. Another potential strategy is decide that I'm going to take the word either increase or decrease and move that up into the stem intentionally and limit myself to a unidirectional sort of solution to this item, and that's represented in the middle column and the right column. The nice thing that happens is the options become shorter. It looks visually cleaner, and it's a more comfortable sort of reading task for the test taker as compared to the set of options on the left. I'm not saying the set of options on the left won't work. It can. I'm just saying that you can also make the choice to present a cleaner look, but that means moving the keyword increase or decrease up into the stem and carrying on from there. Next, we're going to talk about cognitive levels, and this is an area where I observe that writers pretty frequently fall short. And they less than fully understand what it is we're asking when the assignment says, write me a recall item. And we wind up getting this big, long item that goes into a lot more detail than that assignment asked for. Or we say, write us an application or analysis level item, and we wind up with this little bitty stem that's pretty short on much of any detail. And those are two kind of big fails when it comes to satisfying what's necessary for this examination. So let's start with recall items, which are only going to ask someone whether they can pull from memory a fact that exists out in the world. And that fact would be in their memory because they were taught it potentially, or they've experienced it, or there's some combination of those two kinds of activities that underlie the fact they're possessing this memory of this fact. Another characteristic of a recall item is usually you can get to the point with one sentence. And so that's a characteristic that I'm looking for when I see that that is what the writer was assigned. And so when it comes to following through on that as the writer, that's a key point to keep in mind. So here I'm illustrating an example. I went to the content outline in the breadth section, and I pulled out a task, somewhat arbitrarily, but it was a task where the breadth section does allow recall, application, and analysis items so that I can illustrate to you how one can get any of those complexity levels from the same task. And so our content domain comes from Roman numeral 1, which its descriptor is patient data. Subdomain D, which is evaluate procedure results. I'll emphasize that's as opposed to doing the procedure. And that's a key difference here or unique characteristic of this examination and this part of the examination is there is a section that precedes this one, section C, where it talks about doing the procedure. But this is evaluating procedure results. So this is after the procedure's been done, the information has been gathered, and the expectation is that a respiratory therapist is now going to evaluate the information that was gathered and either reach a conclusion or take some action on that basis. And then more specifically, we have oxygen titration with exercise as the specific activity. And so here you see the item that I constructed intended to cover the So we start out during a set of trials to titrate oxygen during exercise. Vital documentation, typically contributing to the assessment is the patients, and then we get to a key. There are some kind of important words in the stem. Typically is one of them. So, you know, this selection should be based on what's typical. Another keyword is vital. All these things are potential documentation, but we're saying one of them is vital. And or even you could combine that, typically vital, to the evaluation of these results. And so as you begin to sift through the distractors, which are A, C, and D, a candidate test taker is going to presumably repeatedly ask themselves, do I typically assess ejection, cardiac ejection fraction at rest as a part of evaluating an oxygen titration trial? Probably the answer is no. Do I regularly or typically, while the patient is in the middle of exercising, get a blood pH, which means getting an arterial blood gas sample as they're moving around exercising for the purpose of assessing the blood pH? Typically not. While they're exercising, am I getting an ECG? This is not, oxygen titration with exercise is not the same as going into a lab for an extensive exercise test where you're on a treadmill and you're hooked up to all the wires and so forth. That's not what this story is. This is done out on the floor in a clinic. You're walking up and down a hall. It's that sort of an activity. And so, you know, the point here is in order for me to evaluate whether an oxygen prescription is going to be necessary, I need to know where the patient was at baseline. And so that's what the option B is. I need to know the starting point. Before we started exercise, before I started making adjustments in the oxygen liter flow, where were they at baseline? And that is typically vital to the evaluation of the results. And so that's why we wind up here. And another key point here is that what makes this recall is that it's describing a recollection of a learned fact, which just really takes a single step. Do I typically do this? Is it vital? Pretty simple, straightforward. Here we are. That's recall. Now, proceeding to application items, the characteristics that I expect to find is there a formula in there? Is there a calculation? Is there a graphic that somebody has to interpret? Is there a table of numbers? Well, maybe that'll be a tool we can use for this next item. Is the candidate caused to interpret what they see, to put stuff into buckets or categories or classifications? Are they asked to translate? Are they asked to reach a conclusion about what they've just evaluated? Are they asked to recognize relationships between things? If any of those things are true, then that is a hallmark of an application level item. And then it will take more physical space in the STEM in order to present all the information that's necessary for the individual to consider. So here's our sample item, same task as I emphasize that. So this is just illustrating a way to take the same basic content, spin it in a different way. We wind up with an application level item. So we have a patient with a chief complaint of dyspnea on exertion. They're assessed with an oxygen titration study involving shuttle walking in the clinic. So that hopefully that sets a scene, describes a visual picture for the test taker about what this activity involved. And understand this is in the past tense because it's all been done. Again, this is not about doing that part of the assessment. It's about evaluating the results from the assessment because it's coming from this 1D area as opposed to 1C where it's about the performance of the procedure. So the results are in the table here. We can see that at rest at minute 0, the patient had an SpO2 of 86. That's notable. Potentially, we see that after 2 minutes of walking with no oxygen, their SpO2 dropped to 84, okay? We added a liter a minute, and then as they continued to walk back and forth, shuttle walking, indicating back and forth, up and down a hall, by minute 4, their SpO2 had come up from 84 to 89. And then we went ahead and added another liter, and a couple minutes later, we were able to measure a 91, and then presumably we stopped because there's no more data. Another thing that pops up here is according to CMS guidelines. That should cause a test taker to stop, say, oh, now I'm going to have to remember information from CMS guidelines that intersect with this story. And I looked this up a couple weeks ago, and what I found was a threshold value of 88, an SpO2 88 being important to the story. That if the SpO2 was below that threshold, then that would qualify someone for oxygen. If they were below that threshold at rest, and then of course if it gets worse during exercise, that would be a sort of an automatic qualifier. But then what really drives home the point about this being application is the very last part of the STEM. Which of the following is the best conclusion about these results? We're asking people to make a conclusion. We're not asking them to do anything with it yet, just what's the conclusion? And so here we have our options. The things I want to point out about these options are visually, they're all about the same length. It's also clear that each of them is a sentence, and therefore they are presented as sentences. Initial capitalization, period at the end, okay? Sometimes options are quotes, things that either the patient would say, a parent would say of a child, or the therapist might say, and sometimes we have literal sentences presented with quotes when it's something that we want to characterize as being stated as some alternatives. But what we have here is, again, recognizing that threshold of 88, recognizing that this patient at baseline was below that, and it got worse with exercise, and then it got better with a liter a minute, tells us, yeah, this patient does qualify for home oxygen. And then the rest of these are just sort of creative takes on ways of coming up with less than the best kinds of answers. No reason here to only prescribe oxygen for active periods because at baseline, the patient was below that threshold of 88. No reason to go up on the liter flows all the way to 4 when they already crossed the threshold just at 1 liter. And then no reason to have sort of arbitrarily continued up to the 10-minute mark. We went for 6 minutes, as far as I know. I only looked for a brief time, but as far as I know, there's nothing in the CMS guidelines that says you got to do the test for 10 minutes. So but it's plausible potentially to someone who knows this area less well that they might think that could be correct. And again, because we presented it in a way that looks similar to the key in terms of length and detail, there could be people who make that choice. What makes this application is, again, we're asking folks to make a conclusion. They have to recall some facts from the CMS guidelines. They have to interpret the table, and that creates at least 3 steps in the mental process of arriving at the right answer. So that's why this is at the application level. So for analysis, the key distinction between application and analysis is analysis will describe problem-solving actions as opposed to conclusions. And so otherwise, I would say, especially the stem of an application and analysis item can look very similar. In fact, what I'm illustrating here is it's essentially the same. All the way down to the phrase, according to CMS guidelines, all of this is the same as we just saw with the application item. The only thing I changed was the last little bit. A home oxygen prescription should be expected for, and here's the problem-solving action, 1 liter a minute of oxygen. Okay? And so this is all intentional. All these options, again, as a set, they look similar to one another. There is actually an intentional creation of 2 pairs because we have A and B options that end with the word periods. We have the C and D options that have the phrase liters a minute of oxygen. Okay. And so again, all this construction of the options is really intentional, and we're asking the same thing of you as you produce your items. And again, we have about 4 steps occurring in this because we have recollection of facts, we have interpreting the table, we make a conclusion that the test taker is internalized, and then they connect the conclusion to an action, and there we get 4 steps in the mental process. So this is analysis item because it solves a problem, describes an action. Okay, we're going to proceed to general instructions for writing. And let me first cover a little bit of glossary of terms. I've already begun to use some of these terms, but this will, hopefully fill in that sort of knowledge gap that I left. But we have in a multiple choice item a stem, which is where we start and tell the story. We then have a set of options in broad strokes. That's a multiple choice item. Within the stem, we can specifically talk about the last sentence or phrase and refer to that as the stemmed options connector. Okay. And there are different choices one can make about how to present that, as we'll talk about here in a little bit. Among the options, we have all the incorrect or less than the best answers. We call those distractors. And that term is intentionally used because the intent of the writer should be to distract a less than fully knowledgeable individual from the correct answer. You want to misdirect them if they're willing to go that direction. And then lastly, we have the best answer among these 4 that we designate and call the key of the multiple choice item. Let's talk for a moment about intention. Never is it the intention to trick or purposefully confuse. Despite what people say, despite what people think they experience while taking tests. That is not the intent. And one of the key characteristics that I'll point to as a way to reinforce that point is I will ask, we will ask after content comes in, we have an examination committee with us, and verify that wrong answers are indeed describing real things. We don't use made up ideas or made up combinations of words or concepts to made up drug names, as an example, made up Latin phrases to describe one thing or another that don't really exist in real life. And so understand that our intention is to assess abilities. And on the other hand, while it is okay to put together combinations of real things that typically don't go together as a way to assess whether someone is really knowledgeable in this area. In other words, what I'm getting at is don't worry about offering up something to somebody. Don't be afraid they may come away from that experience thinking, oh, that's okay. Doing those things together, that could be okay. No, it's a wrong answer. They're going to get the item wrong. And that's the intent. We're not here to try to give propaganda to individuals with the examinations. It's purely about assessment. So another intention is summarized with this slide, which is where are we targeting the difficulty or level of challenge created by these items? And a quick response is moderate difficulty, a medium level of difficulty. Well, what does that really mean? Along the x-axis, what you'll see is the metric for item difficulty, which is the proportion who correctly answered. So the easiest items are over on the right, where the proportions are high, like 80, 90, 100. The more difficult items are in the middle and to the left, where you're only seeing 60, 50, 40, 30% of the test-taking group correctly answered. The curve here, the parabolic curve, is describing the relationship between the item difficulties across the range and the contribution that any of the items will make to the reliability of scores. Reliability of scores is paramount. If we're making inaccurate measurements, then we don't have an examination that's worth giving. And so the more accurate we can make the test scores, the better. And that's really the intent here. So I'm going to throw in these two arrows to define the boundary of what I would call moderate difficulty. It's a fairly wide range, you can notice. You can see that at the 0.5 area, that's where contribution to reliability is maximized. You can also see that at 40 and 60, the contribution is nearly as much. Likewise, 30 and 70 and everything in between, nearly as much. So I put one markup here at about 85. If you're getting 85% or 9 out of 10 of folks correctly answering an item, while that can be useful in an education setting, it's not useful in a setting that we're talking about here, which is sort of end of experience, summative kind of assessment that we need to make with this examination. And so we need to see items that are more difficult than that in order to make the contribution to reliability that we need. Now, having placed the mark at 85, it could be reasonable to ask, well, why isn't the low mark or low boundary not at 0.15, which would sort of be the symmetrical place in the scale? And the reason is that we're talking about 4 option, multiple choice items, and making a pure guess still has a 25% chance of success. And so that's where our low mark is. And so when we see items that have difficulty indices that fall below, at or below that point, we recycle those, send them back to the exam committee, rework them, and try them again potentially, or discard them. Because again, what we're looking for is middle difficulty in these items. For STEM formats, there are really two choices. You can ask a direct question, as you see illustrated in this point, or you could stimulate a similar response with an indirect question. This is purely a style choice that the writer makes. So among the options, the key is justified because it's better than the other three options. A mistaken assumption that is sometimes made, or maybe often made, is that the key has to be the best in the universe of all possibilities. And that's not the case. It's okay for the purpose of assessment to pick out a point and see whether somebody can judge, evaluate that that's acceptable given the scenario we have described. And distractors, and again, another kind of false assumption is they have to be absolutely incorrect under all circumstances. That's not true. You could have an action or an option that is deemed by experts to be acceptable. However, it's not the best in comparison to the key, and there again, it can be counted wrong and called a distractor in that setting. For STEMs, a key point I want to emphasize is you want to approach these from a positive point of view. So you're going to direct test takers to find the best answer, the next thing to be done, the first thing to be done, the priority, what's vital, what's typical. All those things have a positive sort of spin on them, as opposed to finding the exception. Having a list of 4 things, 3 of them belong, 1 of them does not, pick out the one that does not. That's a temptation because it's easy to come up with right answers. It's a lot harder to come up with wrong answers, is what leads to this sort of writing result. And so this is a slide intended to discourage you away from constructing those sorts of items. Another key point that I'll say is we are not accepting new items in the complex multiple choice format. These are items that have a stem, and then before the stem ends, there'll be a list, 1, 2, 3, 4 of elements. And there could be different things in the elements. It could be a word, a number, a phrase, a sentence, who knows. But then those elements get combined in different ways among the options. 1, 2, and 3 only. 1, 2, and 4 only. 1, 3, and 4 only. 2, 3, and 4 only would be the way the options appear. So again, we're not accepting new items of that kind of style. So within the stemmed option connector, a typical recurring choice that you'll have is, do I use the phrase which of the following, or do I use the word what to start my The guideline is this. Compare your item to what happens outside the setting of the item. And if your key is the only thing that's true in the outside world, then you use the word what. An illustration is here, kind of playing on what we were talking about before. According to CMS guidelines, below what threshold must a patient's SpO2 fall to qualify for home oxygen? There is one definitive answer to that. Again, a couple of weeks ago, I think I found that number was 88. There's no other number. It's not a range. It's just one number. And so it would be proper, as this illustrates, to use the word what as a fundamental part of presenting the question. In contrast, if you compare your key to the outside world, and learn that your key is just one in a group of things that could be okay to do or could be acceptable or judged to be correct by experts. Then you use the phrase, which of the following? And so that's just a more accurate way to present your information relative to what you know exists in the outside world. Use a third person style of writing. Some examples are given here. The other point of this slide gives me the chance to say, do not use pronouns. Don't say you are the respiratory therapist, and start off setting the scene in that way. Instead, just say a respiratory therapist is or does, and so forth. And so that's just a choice that we make. The reason we make it is by avoiding the you or the your. Hopefully, we encourage people to come at the items from a broader national evidence-based point of view than if we were to use the pronoun. If we say you, then we're saying, tell us what you've experienced. Well, you've experienced a limited range of settings. You've only done clinical in so many places. You only have worked in so many places. And so you haven't worked at every institution across the board. And so that's a key reason why we make that stylistic choice with our writing. Take care that you avoid irrelevant sources of difficulty. We want the stems to be written with plain and simple language. Shorter words are better, simpler words are better. Yes, there are in this content domain certain technical words or vocabulary that someone must have mastered. Medical terminology, somebody must be able to read. And so there are some big fancy words that show up in the item content, but we don't need big fancy words when describing stuff that's not clinically related. And so instead, what we want to see is simpler writing, 8th grade level reading within those parts of the items. Another key point is occasionally you'll present an item that's going to cause someone to do a calculation. Keep the steps within the calculation to a minimum. As an example, if you have a 4-step calculation, somebody gets it wrong, you don't know exactly at what step they messed up. And then that also becomes a content validity problem because you can't really explain why somebody got it wrong. So again, keep calculation steps to a minimum. The recommended sequence for writing these items is start at the top, start with the stem. You got to tell your story. You got to present your case first. And then in that stemmed option connector, you're going to make a choice. Usually it's going to be between what, starting the sentence with what, or start with which of the following. Or sometimes those words, as we saw in the example, get embedded in the middle of the sentence. It all depends. Another vital point on this slide is write the key before you write the distractors, because the key is going to give you a visual model for the way the rest of the options are supposed to appear in terms of length, in terms of whether it's a sentence or not, and so forth. But the goal, again, is to cause the distractors visually to look similar. Stemmed option flow, you got to pay attention to 2 things. And this is especially after you've written your first draft, you go back and you reread with the intent that you're probably going to revise, but pay attention to whether each option flows from the stem. Word flow is kind of a technical term, specifically related to item writing. But there are 2 little tests. One is there a logical connection between the options and the stem, or the stemmed option and connector? And is there a proper grammatical connection as well? and we get a lot of flawed items come in of this kind. But here's an example of an illogical connection. The STEM says, what should the clinician do next? The STEM is saying something's going to happen. And so having a distractor that says nothing is illogical. What, if anything, should the clinician do next is a fix to the logic part, but it's still not all that good. It's better than to find another way to say that nothing's going to happen. Nothing should happen at the moment. Let's just watch and see what happens, which is continue to monitor. So that's a little tool you can use when you want to communicate that, well, let's just pause, let's see what's happening, let's evaluate, and carry on from there. Here's an example of what I characterize as lazy writing, where someone kind of gave up by the time they gave up on coming up with creative solutions when they got down to option D. And so I'm just encouraging you to do better than this person did. Another thing to pay attention to after you've written the first draft is what is the STEM weight, meaning just what are the number of words in the STEM as compared to each of the options. And if you see the scenario on the left where the options contain more words are longer than the STEM, that's a problem. So what needs to happen is some rewriting, so words get moved from the key up into the STEM, and so you can then present a shorter set of options as you see illustrated on the right-hand side. Another flaw that oftentimes shows up is a word or a phrase will get repeated across all the options. When that happens, the repeated words or phrase needs to be moved up into the STEM, and that's a part of the activity of rewriting. And so what we wind up in the options are shorter options, cleaner looking, just a better item. When thinking about options, you should offer distractors that you know test takers will be attracted to. So you should anticipate the calculation errors they make. You should run the calculation wrong, see what that answer is, put that in as a wrong answer. Use common misconceptions that you know people hold and offer those up in wrong answers. Use language that candidates will find familiar. Use impressive sounding words in wrong answers just as much as you do in right answers. All these things will help distract the less than fully knowledgeable individuals who should succeed on the item. This is a point that I've said before, but it just emphasizes that options should appear similar within the set in terms of length, detail, whether they're sentences or statements. Also, again, repeating the idea about if you have elements that get repeated, you need to use the right ones and the wrong ones an equal number of times. Here's a flawed example. They actually came from a physician examination, but our first option A is not a sentence. Now, that'd be okay if all the other options were likewise not sentences, but option B is a sentence, but it's a short sentence in comparison to D, which is pretty long in comparison. C comes back to not offering a sentence. And then D is an especially long sentence in comparison to the other. So there's a lot of mess going on here. But there are solutions. And so to pick up on this idea that you're going to rewrite your items after you've initially written them, here's how this can be managed. So take a look at option A that used to say just percutaneous liver biopsy. When the target is to come up with a longer sentence, that can become take a liver biopsy using a percutaneous procedure. So that's just a little longer, more detailed way of presenting the same idea. Instead of the very short two-word sentence, which is discontinue amiodarone, we could instead say, prepare to discontinue the amiodarone drug therapy. Kind of throwing in throwaway words that just make that sentence appear longer. Oops. Back to C, we have referral to hematology oncology. Again, that's not a sentence. It needs to become one. So it would be refer, becomes a verb, this patient to the hematology oncology service. And then D was a sentence, a fairly long before, but we're still going to refresh that a little bit by saying, asked to have the lung tissue cut again with a special stain, actually intentionally simplifying the words that are used. So instead of request, we say ask. Instead of saying calling out pathologist, we leave that unsaid. And so we again wind up with a set of options that all look to be about the same. And for someone who's going to guess, they don't really have, they're not pointed in one direction or another just by the construction of the options, which is the goal. We can talk about option difficulty titration. If 89 is the right answer and all we're going to offer are some numbers, then you have a choice as the writer about how closely you approximate the other values to that right answer. The set on the left would be the most difficult to wade through because the interval is pretty tight. The middle one here will be a little less challenging, and then this will be even less challenging. But the point is not to maximize difficulty. Again, the goal is to hit a moderate level of difficulty. And so you should be thinking about the likelihood of success in the test-taking population and match up the intervals to satisfy that goal. We never want to see ranges that overlap among options is the point here. Again, a common flaw that we see when items are submitted. Please don't mix units of measure among the options. In the upper example, we have 4 different units of measure. The thing that really becomes confusing is the option that's actually describing the fewest or the smallest quantity has the largest number presented in it, so 7. And yet, when the units get added, it's really talking about the shortest period of time. And so you need to make it obvious. Again, we're not here to trick, but you need to make it obvious which of these is smallest, which is the largest, which of those fall in between by using the same units of measure. Avoid tipping off the key by putting the exact same word or phrase in both the key and the stem. Sometimes that means using a synonym, or there can be other solutions that are probably better. Likewise, it's best to avoid only using technical detailed, scientific sounding fancy words in the key. Avoid tipping off the key with the qualifiers that you use. So less precise qualifiers, and here's some examples, will logically more likely be true, whereas more precise qualifiers, or the most precise or absolute qualifiers like never, none, all, only, always, are less likely true just from a logic point of view. So you got to be careful about where those get placed among a set of key and distractors. Last point here is that sort of like we're not accepting any new complex multiple choice. We're also not accepting items that come in with these sorts of options, either all the above or none of the above. Either scenario will threaten validity, and they tend to cause more measurement error than they're worth. And then the last point I'll make is I encourage you to come at this from the expectation that you will revise your writing. Better writing comes from revision. It's just a flat statement. And so please do so. Don't procrastinate till the last minute. Get an early start on these. And, you know, on your own, I'd encourage you to, in the interest of producing high quality items that are likely to be accepted by a committee of your peers, please revise. And lastly, you'll be interacting with our examination coordinators who are described here, along with their email addresses. And then the last thing I'll say is eventually I'll be the one who's making the first pass at evaluating your items and whether they are good enough to go in front of the examination committee. And so if you like, I can take a look if you want to send them to me at that email address, and I can give you feedback before you do your final submission if you choose. And so I'll offer that up to you and encourage you to do your best. The other thing I'll say is we've had about 150 individuals volunteer for a seat on the examination committee. We're not going to have a committee of 150 people, so we'll be working through a process of looking who we need to represent on the committee in terms of the different kinds of programs that there are, and also, I'll be honest, we'll be looking at the results from this item writing as an indicator of those individuals who becomes obvious really understand, really get what we're trying to get at with high quality items. And so, we're going to convene that group for a 3-day meeting. They'll be approving something like 55 items a day, which is moving on at a pretty good clip. That's an item every 6-7 minutes. And so in order to expect to do that and succeed at doing that, we're going to need people who have demonstrated they know what they're doing when it comes to managing content within these items. And so in addition to us building an item bank by asking each of you to come up with 4 items, we're also giving ourselves a solid basis to evaluate the performance in item construction, which we're going to need when we get to appointing people for the committee. So that's what's going to come. I appreciate your time and attention to this training. Thank you.